Welcome back to part 2 of OBG PYQs from the FMGE Recall Rush. Hope you are prepared to tackle the questions coming your way. You will be provided with 5 seconds to answer the question, after which the answer and the explanation will be revealed. Without wasting too much time, let's begin.
Question 1. What is the level of the uterus immediately after delivery? Here are the options. A. Below pubic symphysis. B. Above pubic symphysis. C. Below the umbilicus. D. Above umbilicus. And the correct option is D. Above umbilicus. Here is the explanation.
What happens to the size of the uterus? How does it involute? Involution means a reduction of size. So that involution which happens is to make you understand that when we discuss how the uterus grows, we were telling you that at 12 weeks it is just inside the abdomen, at 24 weeks it's at the level of the umbilicus, 36 weeks it's at the level of the xiphisternum. Now after delivery, where is it seen? So immediately after delivery, now that is what is a very important concept for you. I'll tell you why. The uterus is at or just below the level of the umbilicus. If you see, this is the vaginal opening here. So uterus is just below or at the level of the umbilicus. Now why am I stressing so much here? Because when the uterus is an abdominal organ immediately after delivery, then you can see the fallopian tubes here, they are present. Then I can next day or within the first 2-3 days after delivery, I can attempt and do an incision on the abdomen, go inside the abdomen and ligate this tube here and ligate this tube here in a puerperal sterilization. I've had a big discussion about this, about contraception and puerperal sterilization. I'm sure you people have read that part of the video in the app. But please remember, the uterus is a abdominal organ. That's why you can do a tubectomy nicely. It's called the puerperal or the postpartum sterilization. And the best time for that is the first 2 to 3 days. First 2 to 3 days is the best time for you to do a postpartum ligation because the uterus is an abdominal organ. But remember, at 2 weeks it becomes a pelvic organ. The uterus goes back into the pelvis. So when it is inside the pelvis, you cannot make an incision and do a easy sterilization. That's why we say a puerperal sterilization is best done in the first 2-3 days. First 2-3 days is best, the PS, puerperal sterilization. But maximum I say is around 7 to 10 days, because in 10 to 14 days or roughly 2 weeks it becomes a.
Question 2. A young sexually active female patient presented to the outpatient department with complaints of lower abdominal pain, fever, vomiting, and foul-smelling vaginal discharge. On examination, the body temperature is 103 degrees Fahrenheit. The pulse rate is 109 per minute and there is abdominal tenderness. Cervical motion tenderness is present on examination. What is the most likely diagnosis? Here are the options. A. Pelvic inflammatory disease. B. Endometriosis. C. Adenomyosis. D. Appendicitis. And the correct option is A. Pelvic inflammatory disease. Here is the explanation.
The symptoms are mostly pain abdomen and dysmenorrhea. What type of dysmenorrhea? Congestive dysmenorrhea. We discussed that in the first class. And dyspareunia, painful intercourse. She may complain of some fever. And when I examine her, what are the signs? She may be febrile. And if the temperature is more than 38 degrees centigrade, that is 100.4 degree Fahrenheit. If that is the temperature, then she has to be admitted. You know what else are the reasons of admission in PID? Yes. The other problems which compel us to admit a woman, apart from the fever, is that the patient is not becoming better or there is a suspected abscess. So yes, I can admit, I've told you one reason. I can also admit if there is severe symptoms or she's got a suspected pelvic abscess. or she's unreliable. Unreliable, that she's probably not going to take the drugs properly. Alright, so if she's not going to take the drugs properly, compliance is a problem, then I would better admit her and give her antibiotics in the hospital. And then there could also be sometimes a problem that a woman has fever, pain, abdomen, and you are suspecting PID, but it can be so many other things. It can be endometriosis, and the patient has severe pain. So when you are uncertain about the diagnosis with these symptoms, then also you admit. So fever, severe symptoms, abscesses of the ovary, abscesses in the pelvis, pelvic abscesses, all right, that can be a presentation. And they can be a patient who is probably not going to take the antibiotics properly, or she is not tolerating the antibiotics properly, then and uncertain diagnosis, then we would admit the patient. So that's about the symptom of fever, and the patient could be febrile when I see the signs. What else are the signs? I'm continuing the signs here. There could be increased C-reactive protein. There could be a leukocytosis. But on a pelvic examination, PV, per vaginal examination, there might be something called the cervical motion tenderness. Now I've written that in block and I've made an exclamatory mark. Please do not forget this sign. Two places in gynecology: cervical motion tenderness in PID and cervical motion tenderness in ruptured ectopic pregnancy. Both the places you must remember.
Question 3. What is the cause of LH surge? Here are the options. A. Follicle stimulating hormone. B. Estradiol. C. Progesterone. D. Luteinizing hormone. And the correct option is B. Estradiol. Here is the explanation.
The follicle is growing from the first day of the menstrual cycle. It becomes a mature follicle around the 14th day, which is around 20 millimeters in size, and that makes around 200 picograms of estradiol, which gives a feedback to the brain to cause the LH surge. And that LH surge ruptures the follicle, releases the oocyte, and makes the corpus luteum, which now makes progesterone.
Question 4. Identify the hormone present in the contraceptive shown in the image below. Here are the options. A. Nonoxynol 9. B. Octoxynol 8. C. Menfegol. D. Levonorgestrel. And the correct option is A. Nonoxynol 9. Here is the explanation.
Contraception is the sponge. It is the sponge of nonoxynol 9. It's known as today. This sponge is put into the vagina, can be put just before intercourse, and it works for 24 hours. So this sponge has nonoxynol 9.
Question 5. IUCD having the longest lifespan is? Here are the options. A. Progestasert. Copper T380A. C. Mirena. D. Nova T. And the correct option is B. Copper T380A. Here is the explanation.
Like this is the copper 380, and the arms will also have, so 380A, that's why they say this arm will also have some copper rolled over it. So this is the 380 is the amount of copper, it is in millimeter square, the amount of copper in this device, and these arms can be can be gold, the metal can be gold or it can be silver, on which this copper is impregnated. And then there is this age, how long can you use the copper devices. These copper devices can be used up to 10 years. So that's why we always say IUCDs are one of the best devices to be used. Why? Because they fulfill this criteria of fill it and forget it. Once you put the copper T or the the hormonal devices, whichever device you use, once it is inserted, after that the patient doesn't have to remember about using a contraceptive pill or a barrier whenever she is planning to have an intercourse.
Question 6. Serial monitoring of serum beta HCG is required for which of the following conditions? Here are the options. A. Down's syndrome. B. Pregnancy associated with neural tube defects. C. Molar pregnancy. D. Rh negative pregnancy. And the correct option is C. Molar pregnancy. Here is the explanation.
And the HCG follow up, very important aspect of the treatment of a vesicular mole, because it's the HCG value which is the marker for persistence of trophoblastic tissues and maybe even becoming a choriocarcinoma. So, what is the method of HCG follow-up? That will take more of a time to discuss. You must do a weekly HCG estimation till it's negative. So, yes, a vesicular mole might take 9 weeks generally to come to the negative value. A partial mole may take 7 weeks to come to the negative value. Mind you, the answer is given as 8 and 6 weeks in some of your favorite books, which is wrong. Okay, 9 weeks and 7 weeks. This is the one which is the Royal College and the American College recommendation, when the vesicular mole and the partial mole would come down to its normal values. After they are normal, you will still do weekly till 3 more weeks. Another 3 weeks you will follow up, even though it was negative at 9 weeks, for example, and then once in a month for another 6 months. Now, long back we used to say 2 years of follow up, then we made it 1 year follow up. Now they say at least 6 months of follow up, and in this follow up we will be very strict that the HCG should not rise. Now, if it has not risen for 6 months, then you can stop.
Question 7. A 27-year-old woman presented with a malodorous discharge in the vagina which started a week earlier. On examination, Whiff's test is positive and the gram stain shows the presence of clue cells. This infection is commonly treated with which of the following? Here are the options. A. Metronidazole. B. Nystatin pessary. C. Tetracycline. D. Azithromycin. And the correct option is A. Metronidazole. Here is the explanation.
Bacterial vaginosis and trichomoniasis together. These two are known to happen in the alkaline pH. Now, I said the acidic pH is 4.5 in a normal woman, and we know that the alkaline pH, which is common to both of these, is more than 7. Yes, we know that. But if the pH is shifting from 4.5 to just 5.5, although it is still in the acidic range, I say it is lesser acidic and pertaining towards alkalinity. So, even that shift is enough to cause these infections. Please remember, absolute alkalinity can happen. Old women will have pH more than 7, and that is absolute alkalinity, and they have trichomoniasis and bacterial vaginosis many times. But yes, even relative alkalinity. Remember, so many television ads come and say when there is a shift in pH and there can be some vaginal infections. So, shift in pH just from 4.5 to 5.5 to 6. Although it is still in the acidic range, but it is shifting from the alkalinity to relative, it is shifting from the acidity to relative alkalinity. Although it is not absolute alkalinity. So, yes, more than 7 is going to cause alkaline pH, and it is going to cause these two infections, but also 5.5, 6, etc. can cause. So, bacterial vaginosis is by the Haemophilus vaginalis, also called the Gardnerella vaginalis. Now, bacterial vaginosis has a creamy discharge, and it has this Whiff test. Whiff test is positive, that is, on the secretions, if you add 10% potassium hydroxide, it releases amines. So, it gives that ammonical whiff when you add potassium hydroxide 10% to these secretions. Or there is this fishy odor. Now, if you add potassium hydroxide, it releases ammonical odor. That is the ammonical whiff after adding potassium hydroxide. But if you happen to examine a wound with bacterial vaginosis, that fishy smell comes immediately. So, you know that this woman is having bacterial vaginosis just by the native smell of the secretions. Yes, that you don't have to look for the smell. You don't have to try to look for the smell. The smell will come to you. So, the other one is, of course, the clue cells. Very important. The vaginal epithelium with embedded bacteria. So, if you see the vaginal epithelium, you know the cells are these polygonal cells, and you will see one nucleus here. Now, there is so much of bacteria in this. There is so much of bacteria that you may not see the edges, the sharp edges of the cell. They are all frayed now. Can you see the sharp edges? They are frayed. This cell is so full of bacteria that when you examine this secretion under the microscope, it gives you a clue that yes, there is a bacterial vaginosis in this person. So, these are the clue cells, alright. So, we already discussed that this is treated by metronidazole. Yes, treatment is metronidazole.
Question 8. A mother brought her 16-year-old daughter to the hospital with the complaints of primary amenorrhea. On evaluation, axillary and pubic hair were present and other secondary sexual characteristics were normal. LH and FSH levels are normal and USG showed absence of uterus. What is the most likely diagnosis? Here are the options. A. Turner syndrome. B. MRKH syndrome. C. Androgen insensitivity syndrome. D. Swyer syndrome. And the correct option is B. MRKH syndrome. Here is the explanation.
With primary amenorrhea, of course, we have done the pregnancy test and the pregnancy test is negative. Now, we will look for the secondary sexual characters, and if they are present and the woman is not having periods, it could be because that there is an anatomical defect like the uterus is absent. So, if there is absent uterus, then we know that is the Mayer-Rokitansky-Kushner-Hauser syndrome. That is the classical Mullerian agenesis. We have discussed a lot about this in the chapter of Mullerian abnormalities. She will never have periods, isn't it? And if she has to have a sexual life, then we will have to do a vaginoplasty just before she is planning her sexual life.
Question 9. A 17-year-old female presents with primary amenorrhea, but she gets abdominal pain every month. On examination, she has normal development of other secondary sexual characteristics. There is an abdominal lump present and on parting the labia a bluish bulge is noted. Considering the suspected diagnosis, what would be the appropriate management? Here are the options. A. Excision of the septum. B. Extensive dissection and vaginoplasty. C. Cruciate incision on the hymen. D. Hysterectomy. And the correct option is C. Cruciate incision on the hymen. Here is the explanation.
The uterus nicely formed, the cervix is formed, the upper vagina, lower vagina is formed and fused nicely, and the fallopian tubes are formed. But the vaginal opening is not properly cannulated. So, when the vaginal opening is not cannulated, we call it the imperforate hymen. Now, this is not a Mullerian defect owner. I know I am talking about the Mullerian defect chapter, but yes, this patient can also come with the same kind of presentation. It can come with the same kind of presentation that she may have blood collected in the uterus and blood collected in the vagina, and this may present typically with the patient just like a transvaginal septum or a vaginal atresia, that the patient comes and says, sir, I've got pain, a cyclical pain, but I've not had my period so far. A young girl will come to you and say she's having cyclical pain every month, but she's not getting periods so far. She's got a case of primary amenorrhea. So yes, this condition where you will see blood which is hidden is known as cryptomenorrhea. Cryptomenorrhea, and they will ask you conditions where all do you see cryptomenorrhea. Cryptomenorrhea is seen in transvaginal septum, vaginal atresia, imperforate hymen, and cervicovaginal atresia. Imperforate hymen is obviously not a case of Mullerian defects, but I am discussing cases of cryptomenorrhea side by side. And here, when the blood is collected in the uterus, this is known as a hematometra. blood collecting in the vagina is known as a hematocolpos. So, hematometra here, hematometra here, hematometra, hematocolpos here. These are the instances of cryptomenorrhea, and these patients can come occasionally to you with even urinary retention. Now, how does that happen? Now, that is what MCQ came to all of you in the PG entrance exam many times, that this vagina is totally distended because of the blood, and the urethra which is in front, this urethra will get compressed because see this distended vagina with all that blood, this distended vagina with all this blood, this will compress the urethra against the pubic symphysis. See here, there will be compression of the urethra against the pubic symphysis. So, yes, that will cause retention of urine. So, the classical history, the patient comes to you with a young girl with primary amenorrhea. Young girl around 16, 17, they will give in the exam. Young girl with primary amenorrhea and acute retention of urine. So, this is a classical presentation of a patient with a imperforate hymen or even a transvaginal septum. Now, that of course, we have to do the management of these cases individually. We know that a case of imperforate hymen requires a cruciate incision. We all know that a cruciate, a cross-shaped incision. You know, in the hymen we make a cross-shaped incision and then we cut along the edges. So, when we make a cruciate incision and then we cut along the edges like this.
Question 10. During the normal delivery of a primigravida with polyhydramnios, the intern prematurely removes the placenta, leading to profuse bleeding. Examination reveals an intact placenta and that the uterus is partly outside the introitus. The patient is in hemorrhagic shock, so initial resuscitative measures are taken. What is the most likely diagnosis? Here are the options. A. Amniotic fluid embolism. B. Postpartum hemorrhage. C. Uterine inversion. D. Uterine rupture. And the correct option is C. Uterine inversion. Here is the explanation.
After the delivery of the baby, the placenta is attached, let's say, on the fundolateral part of the uterus. We wait for the placenta to deliver, but sometimes we are in a hurry and we want to assist in the delivery. Now, sometimes we hold the cord and we are in a great hurry and we just yank on the umbilical cord. And we just yank on the umbilical cord without noting that the placenta is actually separated or not yet separated. So, yes, if you pull the cord like that, the placenta would pull the attached uterine wall with it, and that is going to cause an inversion of the uterine fundus. So, yes, this uterus will start indenting like this, and then eventually hang out totally from the vagina like this with the placenta attached to it, of course. So, yes, that is what is going to cause a lot of pain. So, the patient has inversion, acute inversion of the uterus, and this can cause a lot of pain, neurogenic shock, and can cause a lot of bleeding, hemorrhagic shock, and both can kill the woman. The neurogenic shock and the hemorrhagic shock both can kill the woman. MCQ asked a few people is, which is the more common cause? No doubt about the fact that most common cause of mortality in a inversion is the hemorrhage. Yes, a lot of us have been taught that it's the neurogenic shock. That's wrong. Hemorrhagic shock is the cause of death in inversion most.
Question 11. A 22-year-old female presents within 8 hours of having sexual intercourse and asking for emergency contraception. She says she doesn't want multiple pills and wants just one pill. What will be your advice? Here are the options. A. Levonorgestrel 0.75 mg. B. Ethinyl estradiol plus levonorgestrel. C. Levonorgestrel 1.5 mg. D. Desogestrel 3 mg. And the correct option is C. Levonorgestrel 1.5 mg. Here is the explanation.
Levonorgestrel. Levonorgestrel 0.75 milligrams. We used to give 2 tablets. Nowadays this also became a question, I don't know why. Nowadays there is 1 tablet of 1.5 milligrams. So either way the dose is the same. Now how does this work? Suppose the woman had intercourse on the 11th day and she comes to you on the 12th day and says, "Doc, please save me, I don't want to have this child, I don't want to conceive." So she's only had intercourse and she says, "Doc, save me." So yesterday was the 11th day and she'll ovulate only on the 14th day. But I know that the sperms can live up to 3 days in the genital tract of a woman. So 12, 13, 14. The sperms will be alive on the 14th day, and if she ovulates on the 14th day, she can still get pregnant with this 11th day intercourse. So yes, what do? Yesterday she had intercourse, 11th day, today she comes to me, I give her levonorgestrel. What is levonorgestrel? It's a progesterone. What is the purpose of LH? Remember those 2 punchlines? Purpose of FSH, estrogen. Purpose of LH, progesterone. So you've given progesterone already. Yesterday intercourse, 11th day, 12th day you've given the progesterone. So yes, this will reduce the LH and that will reduce the ovulation and pregnancy won't happen. So that's the mechanism, that it can stop ovulation. Now situation number 2, she had intercourse yesterday, it was the 14th day, already ovulation has happened. Now the embryo has already formed. Within 6 hours the sperms reach the site of fertilization, isn't it? Some books say they reach within 2 hours. So if the sperms have reached, the embryo would have formed yesterday night itself, and today she's come to you. So can you avoid a pregnancy? Can you avoid ovulation? Too late. But you can now avoid implantation with the same drug. Yes, progesterones will increase the endometrial secretory activity too much. The secretion will be very high. So endometrial secretion should be just the right amount. I always keep telling you that the endometrium should be the right secretory amount for the embryo to implant. But now what has happened, you've given a high dose of progesterone. See, this progesterone, normally you see in your oral contraceptive pills, the progesterone is 0.15 milligrams, isn't it? So that low dose of progesterone is now 1.5 milligrams. So this is much more higher. So that amount of progesterone if you give, the endometrium becomes too secretory. It becomes too secretory and too fluffy. So we discussed in the chapter of contraception the applied information on the menstrual physiology, that when this endometrium is too fluffy, when it is too fluffy, in other words, out of phase, it is too fluffy and out of phase, just too thick for the embryo to sit and implant. Okay, so the endometrium will prevent implantation because it is out of phase, and also the high progesterone will reduce the tubal motility. So when the tubal motility is reduced, then the embryo comes late arrival into the uterus. So that's why also the implantation doesn't take place. Any other method you want to tell us which can help in preventing the pregnancy? When I'm using levonorgestrel pill for this woman who's come for emergency conception, it reduces ovulation if it is before the ovulation time. It makes the endometrium out of phase. It reduces the tubal motility.
Question 12. A middle-aged woman presented with dysmenorrhea, dyspareunia, and infertility. On examination, you note fixed, tender, retroverted uterus and tender nodularity of the uterosacral ligaments. What is the most likely diagnosis? Here are the options. A. PID. B. Endometriosis. C. Pelvic TB. D. Leiomyoma. And the correct option is B. Endometriosis. Here is the explanation.
Get into the symptomatology of endometriosis. The patient may have chronic pain, acute monthly exacerbation, that is the severe congestive. So we call this the severe congestive dysmenorrhea. That's the time when the lady is literally jumping with pain. Alright, then the patient may also have severe dyspareunia. That is what is painful intercourse, especially deep dyspareunia, and menorrhagia. Remember I told you something in the etiology? Yes, in the etiology I told you that if all the 70 to 80% of women who have retrograde menstruation, the ones who are hyperestrogenic have endometriosis. So now that's what is the issue here, that if a woman has hyperestrogenicity, then obviously the endometrium will be proliferating much more. So she may also present to you with menorrhagia. Now, I told you that there will be a lot of adhesions and there might be altering in the tubo-ovarian relation. So what's the result of that? She may also have a symptom presentation of infertility, the biggest headache which I have in my outpatient department. The infertility because of endometriosis, because of the adhesions. Why is there infertility? Because of the adhesions, there is a altered tubo-ovarian relation. So the oocytes are missed. Then, because of the pain, the chronic pelvic pain and the deposits, the intercourse is so painful. So lesser, much lesser sexual activity. I've written intercourse here. Because of the chocolate cyst, the ovarian anatomy is disturbed. So there will be poor ovulation. But the biggest problem is that these deposits which are present all over the pelvis and the uterus and the fallopian tubes and the ovary, these endometriotic deposits are also embryotoxic. All these deposits are embryotoxic endometriotic deposits. Very, very important fundamental. So these deposits, I've drawn just a few to highlight here. These deposits have their own interleukins and the cytokines which will go and trouble the oocyte and trouble the oocyte sperm interaction and also trouble the embryo later. So because this embryotoxic deposits, let me tell you what is the reason of infertility because of these deposits. There are poor quality embryos and there is decreased implantation of these embryos and increased abortions of these embryos. So that's why this patient will also have the infertility. That's what I've told you the causes here. The infertility is because of the adhesions, reduced intercourse, poor ovulation and the embryotoxic endometriotic deposits.
Question 13. A primigravida presents with labor pain and on per vaginal examination her cervix is 7 cm dilated and fully effaced. What stage of labor is she in? Here are the options. A. Acceleration phase. B. Latent phase. C. Deceleration phase. D. Phase of maximum slope. And the correct option is D. Phase of maximum slope. Here is the explanation.
From the onset of contraction to the full dilatation of cervix, but this is further divided into the latent phase of labor and the active phase of labor. You know that the latent phase of labor is generally around 8 hours and the active phase of labor is around 4 to 6 hours depending on the parity of the woman. And then once the cervix is fully dilated, that is after the active phase, when the cervix is fully dilated, we say now the patient is in the second stage of labor. And we know in a multigravida it's around half an hour and in a primigravida it's around 1 hour. So these are the stages of labor as described by Friedman, and further this can also be classified as the preparatory phase and the dilatation phase and the pelvic phase. So the latent phase of labor along with the acceleration phase, this is actually constituting the preparatory division of labor. and from the acceleration phase to the phase of maximum slope. See, the maximum contractions and the dilatation happens in this phase of labor. So, this is known as the dilatational division of the labor, and then from the deceleration phase and to the second stage of labor, we call it the pelvic division of labor.
Question 14. What minimum number of antenatal visits according to WHO is? Here are the options. A 4, B 8, C 6, D 3. And the correct option is A 4. Here is the explanation.
What we ask you in the exam, we ask you the minimal. If not WHO, the Indian setup says minimal 4 visits. So, minimal 4 visits is that first trimester at least 1 visit, then second trimester another visit, and in the third trimester 2 visits. So, at least 2 visits.
Question 15. In a patient being treated for eclampsia, the next dose of magnesium sulfate should be skipped if. Here are the options. A. Knee jerks are sluggish. B. Urine output exceeds 30 milliliters per hour. C. Respiratory rate more than 14 per minute. D. None of the above. And the correct option is A. Knee jerks are sluggish. Here is the explanation.
Giving this intramuscular magnesium sulfate, I must monitor the knee jerks. They should be present because magnesium sulfate acts on the brain and it causes suppression of brain. It increases the threshold of convulsion. We know all of that, isn't it? So, yes, knee jerks are upper motor neuron reflexes. So, if the brain is suppressed too much by the MAC self, the knee jerks will get absent. So, do not give the next injection, hold the next shot. So, knee jerks should be present.
Question 16. A 35-year-old with 36-week pregnancy comes with a history of 5 convulsions at home. The diagnosis made by a doctor is eclampsia. Next, management. Here are the options. A. Leptalol. B. Magnesium sulfate. C. Termination. D. Clonidine. And the correct option is B. Magnesium sulfate. Here is the explanation.
Eclampsia management, the drug of choice, no doubt, is magnesium sulfate. .7H2O is the full formula. So, that magnesium sulfate is the drug of choice. It can be given in the IM plus IV method, which is the Pritchard's regime, or the IV only regime known as the Zuspann's regime. And the method of choice is the Pritchard's regime. So, how do we give it? IV magnesium sulfate 4 grams first, and intramuscular max self 10 grams. Since it is a large volume of a drug, then we must split it 5 grams in one buttock and the other 5 grams in other buttock. So, yes, 14 grams is the loading dose. If there is no relief, plus another 2 grams can be given IV if no relief. Now, this is the acute management, the IV bolus given and the IM given afterwards. So, 14 grams is the loading dose. Now, after giving this, we must follow up the max self intramuscularly for 24 hours after the last convulsion or the delivery, whichever is later, not earlier.
Question 17. The most common organism causing pelvic inflammatory disease? Here are the options. A. Neisseria gonorrhea. B. Gardnerella vaginalis. C. Bacteroids. D. Chlamydia. And the correct option is D. Chlamydia. Here is the explanation.
What are the causes? Now, we are discussing as Indians, and as Indians you will be asked so many times, what is the most common cause of PID? What are you going to say? tuberculosis? Now that's where you're wrong. Tuberculosis is one of the causes of PID. It's not the only cause of PID. Yes, I agree. Yes, you people are going to say that we are Indians and we are poor and we are malnourished. Fine, I know that. We Indians are very poor and we have immunocompromised women, and they are postnatal, they are even more immunocompromised, and we have not well nourished women, so we get a lot of tuberculosis. Yes, correct. But please, we don't get only tuberculosis. We Indians are just as promiscuous like any other country in the world. In fact, I think we are more promiscuous. Remember, we are the most populous country already. We are going to overtake China in another 10-15 years, isn't it? And we are overpopulous because we are having so much of sex, isn't it? You don't have children without that. So please, and we are having way too much more sex. The ones which result in pregnancy, we know there is much more sex happening besides that. You're not liking that. You know, which was the country which published the first edition of the Kama Sutra? Which was the country which has temples made of their promiscuity? Khajuraho? I think both of the answers are India, isn't it? So please, do not underestimate Indians, alright? Yes, we know we are very traditional and we are very cultural and we have a lot of values and I know that, you also know that. But yes, besides that, it is the same country which has written the Kama Sutra and has made temples out of the promiscuity in Khajuraho. So yes, why am I telling this story in PID? PID never happens without intercourse, please. A woman cannot have PID without getting exposed. Yes, 95% what I am saying is correct. There's a very bad immunocompromised, very poor woman who is so immunocompromised that she gets infection all over the body, and part of that is PID. Rare cases, don't talk. PID never happens without intercourse. Okay, you would have seen, I don't know, you're all interns and I'm sure so many of you would have experienced in your outpatient departments that these newlyweds come to you with honeymoon cystitis, and then they keep coming to you for the white discharges and they keep coming to you for the dyspareunia. Why? Because they got infection. Why did they not get infection before marriage? Because there is no other way to get the infection. So I hope this is clear. I'm not going to repeat the story when we discuss CS cervix. In CS cervix also, you must imagine that we get a lot of CS cervix in our country because we are extremely sexually active. Alright. So now, enough about the story behind the PID. So we Indians also get PID just like the whole world gets, and that is because of chlamydia. And that's because of gonorrhea. So chlamydia is the most prevalent. And it is, if I tell you what are the symptoms of chlamydia, actually there are hardly any symptoms. The infection is indolent. Remember I told you when a woman is on oral contraceptive pills, she may have some reduction in PID, but she may have more chlamydia, isn't it? So chlamydia is an indolent PID. A woman does not know that she has PID when she is suffering from chlamydia. That's why she never comes to me. A chlamydia, maximum she may have one symptom, that she is not getting pregnant. But she's already had children and now she gets chlamydia, she'll probably never come to you. So suppose I'm right now discussing this with you sitting in Delhi, and in South Delhi I catch 10,000 women and I do a chlamydial serology. Just random, I go to the homes and take the blood and do a chlamydial serology. You know what, out of 10,000, at least 1,500 or maybe 1,000 will come positive for chlamydial serology. Yes, so much of chlamydial serology might come positive.
Question 18. A woman post-coitus after 96 hours, the best contraceptive of choices. Here are the options. A. OCP. B. IUCD. C. Mifepristone. D. Progesterone only pills. And the correct option is B. IUCD. Here is the explanation.
Choice. Then intrauterine contraceptive device, it reduces implantation, and what is the best thing about it? It is useful up to 5 days, and what is even better is that it is useful up to 5 days. Ella, this drug ELA, this is also used for 5 days, but IUCD is equally effective for these 5 days. The effectivity does not drop. You know, all these progesterones which we are giving for the emergency conception, first day it is best, second day it is lesser, and it may be working, the ELA might be working up to 5 days, but the effectivity might not be as good as it is on the first day after intercourse. So, IUCD is that method which is uniformly effective for these 5 days, uniformly effective. So, this uniformly effective method, most people think that this is the drug of choice for emergency contraception.
Question 19. Risk of endometrial cancer is least in. Here are the options. A. A positive family history. B. Obesity. C. Late menopause. D. Multigravida. And the correct option is D. Multigravida. Here is the explanation.
So, when we talk about endometrium, the etiology is to do with high estrogens, and these high estrogens can be because the woman is on hormone replacement therapy, which you know is to give tablets of estradiol. You could be giving 1 to 2 milligrams per day, or conjugated equine estrogen 0.625 to 1.25 milligrams per day. So, these are high estrogens because it has to take care of a lot of things in the body, the mood swings, the hot flushes, and the bone health and the pelvic health, etc., etc. And to counter the effect of high estrogens in the body, we must add progesterones so that the endometrium is protected, but still HRT is implicated. Then tamoxifen therapy. Now, tamoxifen therapy for CA breast, this is a SERM, and tamoxifen has got estrogenic and anti-estrogenic properties. We use the anti-estrogenic property for the CA breast, but yes, this is estrogenic on the uterine lining, so that can cause the hyperplasia of the endometrium. And if the woman has early menarche and late menopause, so what's the relation with this? Early menarche and late menopause means that the woman is having more number of cycles. Suppose everybody have a period starting from 12th year of their life. If this woman is menstruating from the 9th year of her life, so she's got 3 years extra, and she goes on menstruating till 55, then menopause happens around 52, and then she's got another 3 years extra at that time. So she's got net number of cycles more and net exposure to estrogens more. So this means more estrogen exposure. Then estrogen producing ovarian tumors, you know of granulosa cell tumor, which we've been discussing so many times. Granulosa cells make estrogen, granulosa cell tumors will make much more estrogens. Okay, estrogen producing ovarian tumors are implicated in the etiology of C. endometrium. And anovulatory conditions. Anovulatory conditions, yes, the most famous one, polycystic ovarian syndrome or polycystic ovarian disease, persistently high estrogens, and that is what is going to make the woman have hyperplasias. And PCOS, indeed, a long-term complication of PCOS is to have endometrial cancer. And if the person has obesity, why obesity is associated? Because all of you know that obesity has a problem of increased fat cells. These fat cells, all of you know, are the factories which convert the androgens to estrogens, and more fat factories, more conversion of the circulating androgens to estrogens, and so there is net increased amount of estrogens in this woman. What is also related with this is that there is something called the corpus cancer syndrome. Corpus cancer syndrome, that's the MCQ which you keep getting. What is the corpus? You know, the uterine body is also known as the corpus, and then there is the cervix. So yes, this part is the cervix, this part is the body. So body is known as corpus. So corpus, CA body or CA corpus, corpus cancer syndrome, that's the meaning of this statement. First of all, corpus means uterine body cancer. Corpus cancer syndrome is seen more in women who are having obesity, diabetes mellitus, and hypertension, and that's what is your MCQ, which I told you at the introduction of this chapter, which is regularly coming in exams. And there is also association with abnormal liver function. She's a case of let's say cirrhosis of liver, or she's having some hepatitis long term, which is going to alter the estrogen metabolism, and if the estrogen is not metabolized, it will be functioning much more, running much more longer in the circulation and causing side effects. And if there is also an association with the Lynch 2 syndrome, which used to be earlier called the hereditary non-polyposis colorectal cancer syndrome, HNPCC. So Lynch 2 syndrome, there is almost up to 40% association with C. endometrium. Also very, very significant is the familial predisposition. Now this familial predisposition, remember, the female relatives are the ones who are more likely to get cancers because of this woman having a cancer. Now suppose this woman has CA endometrium, so the other woman can have CA endometrium, but they can also have CA ovary or CA breast. That is familial predisposition. The first degree female relatives or even the second degree female relatives in the pedigree chart, if you see, they are also predisposed, but the first degree female relatives are even more. So what is the association? The association is that the woman can have CA endometrium. Suppose this woman has CA endometrium, her first degree relatives can have either of these. I mean, she has CA endometrium, but her daughter may have CA endometrium or CA ovary or maybe CA breast. So that is the familial predisposition, and you must keep an eye whenever a woman has one of these cancers. Always ask the prevalence of these cancers in the women, the close women relatives in the family at the same time. So what are the percentage associations about the other things which I told you? That if a woman is having this Lynch 2 syndrome, then there is 40% association, but this obesity, this also 1.5 to 2.5 times more likely that she'll have CA endometrium. If she's overweight, then the chance is 1.5 times more. If she's grossly obese, then it is 2.5 times more than another woman who is of normal weight. So that is the association with the weight and then of the Lynch 2 syndrome. But apart from this, very important etiology is the Nully Parity. Now, why Nully Parity is important? Look, Nully Parous woman is a woman who is never conceived. So she has no break from estrogen exposure. So that is what is very important. So when there is no break, that is every month she is exposed to the actions of estrogen, and that is going to cause the endometrium to become more proliferative than the woman who having a break. Now what do you mean by break? The women who conceive have a break from menstruation, isn't it? So that's the problem. Nully Parous women don't have this break. Women who conceive, they have a break of how long? 9 months? Not really. 9 months is the pregnancy break, but then there is again lactation period, and lactation amenorrhea can go from 6 months to almost 1 year. So roughly, because of one pregnancy, a woman has break from menstruation for almost 2 years. So yes, each pregnancy around 2 years break. Now that break is missing. This break is not there in a Nully Parous woman. Nully Parous means who's never conceived, and that's why when this woman is not having this break, she is more likely to have hyperplasias. And in India, on the other hand, now you can understand that in India, there are at least 2 or 3 pregnancies in every family. Sometimes in the uneducated class, the low socioeconomic class, there are people who are having even 4 to 5 or 6 children even now. So yes, the average number of children in a country is still 2.6. So there are people who are having around 3 to 4 children even now. So if there are so many pregnancies happening, suppose a woman is delivered 5 times, she's got a break every pregnancy for 2 years. So with 5 pregnancies, she's got a break of 10 years. So in her menstrual life, she's not menstruated at all for 10 years. That means for those 10 years, there was a uterus without any excessive exposure of estrogen. In fact, 10 years, there was so much of progesterone influence on the uterus. So that's the logic.
Question 20. A grand multipura is a woman who has given birth times. Here are the options. A. More than 2. B. More than 3. C. More than 4. D. More than 5. And the correct option is C. More than 4. Here is the explanation.
Multipara is more than equal to 2 pregnancies. And grand multi is more than 4. That is, or we can also say more than equal to 5. See, that's also sometimes the reason for confusion. More than 4 means 5, 6, 7. Or we can say more than equal to 5. That is 5, 6, 7. Again, means the same.
Question 21. A 50-year-old woman diagnosed with an ovarian malignancy most likely has. Here are the options. A. Granulosa cell tumor. B. Dermoid cyst. C. Mucinous cystadenoma. D. Serous cystadenoma. And the correct option is D. Serous cystadenoma. Here is the explanation.
Tell you, the most common ovarian tumor are the epithelial ovarian tumors or the surface epithelial ovarian tumors. They are seen in older women and they are mostly bilateral. Older, bilateral. When I tell you germ cell tumors, I will tell you something else in the heading. But remember, epithelial tumors are the most common ovarian tumors. They are 70% of all the ovarian tumors and they are seen in older women and they are bilateral. Now, in this, what is the most common? In epithelial ovarian tumors, the most common is the serous cystadenoma. A serous cystadenoma is a unilocular tumor. One loculated collection is present, that is the tumor has just one loculi like this, and it is bilateral in more than 50% of cases. It is mostly malignant. It has this surface excrescences, surface growth, papillary projections, things like that. So, surface growth is present in quite a few of them and it has this samoma bodies.
Question 22. Endometrial carcinoma with vaginal metastasis. This is FIGO stage. Here are the options. A. Stage 3A, B. Stage 3B, C. Stage 3C, D. Stage 4A, and the correct option is B. Stage 3B. Here is the explanation.
So, what is the staging of CA endometrium? So, if you see the uterus and see how it is growing in the cancer. So, what is stage 1? Now, stage 1 endometrial cancer is limited to the uterus, and stage 1A endometrium is involved plus minus less than half of myometrium. The cancer cells are within the endometrium, or if they go into the myometrium, it is less than half of the myometrium which is involved. Okay, now stage 1B, myometrium more than half involved. So these cells are now involved beyond the half of myometrium. And stage 2 is cervical stromal involvement Please remember, now there is only stage 2. Earlier there used to be stage 2A and stage 2B. Now there is only stage 2, and glandular involvement is not taken into consideration. If at all they say it is, if at all they want to talk about glandular involvement, we'll say it is stage 1, but otherwise it's not taken into consideration. So stage 2 is cervical stromal involvement with the cancer. So the cancer cells have started growing to the cervical stroma here. And then what is stage 3? Now stage 3A is uterine serosa plus the positive peritoneal cytology. And stage 3B is classical MCQ, very, very important, vaginal involvement plus parametrium involvement. Please remember, vaginal involvement in endometrial cancer, vaginal involvement in cervical cancer, and in ovarian cancer. So all of these cases, see, nobody is going to ask you to write the staging of these cancers. They'll ask you specific events. So vaginal involvement, inguinal lymph node involvement, they become very important questions in your exams. So what is stage 3C? Stage 3C is C1 and C2. C1 is pelvic lymph nodes involvement and C2 is para-aortic lymph node involvement. Now what is stage 4? Now this stage C, you know, this same stage here is now mentioned in cervical cancer also. Remember, I have taught you in CA cervix that stage 3 is now modified to stage 3A, 3B, and a new stage 3C has been added in CA cervix. I'm just mentioning here so that when you read CA cervix, you don't forget this important stage. C1 is pelvic lymph node, C2 is para-aortic lymph node. Same stage is there in CA cervix now. So stage 3C is this. Now what is stage 4? Stage 4A is bladder plus bowel involvement, and stage 4B is distant metastasis plus inguinal lymph node involvement. Very, very important. Inguinal lymph node involvement.
Question 23. The Ferning pattern of drying cervical mucus suggests the action of. Here are the options. A. Estrogen. B. Progesterone. C. Prolactin. D. 17 ketosteroids. And the correct option is A. Estrogen. Here is the explanation.
Cervical mucus studies. What about the cervical mucus studies? We discussed in the first class that the cervical mucus is thin and watery, spin bucket is maximum, and the ferning is maximum on the 14th day of the menstrual cycle. So does that tell you about ovulation? No. Now that's the problem. We always get this question wrong when we read our average guidebooks. Please understand, spin bucket and ferning, I repeatedly told you, is because of estrogens. It's highest on the 14th day, remember? So if the spin bucket and ferning is because of estrogens, and for ovulation, I told you in the beginning of this topic, what do I want to see? I want to see the effects of progesterone, isn't it? I want to see the effects of progesterone. So yes, let's not confuse ourselves. When I want to do cervical mucus studies, I want to actually look for the effects of estrogen and progesterone. I want to see the effects of progesterone. When the woman ovulates, the effects of progesterone on the cervical mucus I want to see. So yes, I do the PV on the day 8 and see cervical mucus is not so thin. On the day 10, somewhat thinner. Day 12, good thin. Day 14, thinnest. It is stretchable so much. On day 16, when I do the PV and examine the cervical mucus, it is thick now. Day 20, really, really thick. Now, when the cervical mucus has become thick, that means the patient has ovulated. So please remember, it's very important to understand, cervical mucus studies are serial cervical mucus studies. They are serial cervical mucus studies, and very important to understand that loss of spin bucket and ferning,
Loss of spin bucket and ferning is what is ovulation. Spin bucket and ferning is never ovulation. Please understand, spin bucket and ferning is because of high estrogens, and once the ovulation has happened, then the effects of progesterone will come on the cervix.
Question 24. If a zygote divides 2 to 3 days after fertilization, which of the following type of twining is seen? Here are the options. A. Monochorionic, monoamniotic. B. Monochorionic, diamniotic. C. Diamniotic, dichorionic. D. Dichorionic, monoamniotic. And the correct option is C. Diamniotic, dichorionic. Here is the explanation.
Split happens. If the split of the embryo happens less than equal to 3 days of embryological life, intrauterine life, then there will be complete split. There will be one placenta and one sac with a growing fetus. There will be another placenta, another sac with a growing fetus. So that is what is known as the dichorionic, diamniotic twin. Now this is around 30 to 35% of the monozygotic twins.
Question 25. Chromosome pattern in complete mole. Here are the options. A. 46XY both maternal origin. B. 46XX both maternal origin. C. 46XX both paternal origin. D. 46YY both paternal origin. And the correct option is C. 46XX both paternal origin. Here is the explanation.
The formation of a complete mole. A complete mole, we have to understand the fundamental of an empty oocyte. An empty oocyte gets fertilized by a sperm carrying 23X. Mind you, it can never happen with a 23Y. So when a 23X carrying sperm enters the oocyte, which is empty, now this oocyte does not give any genetic material, but the sperm gives a genetic material which makes a pronucleus carrying 23X. Now this is an empty oocyte but not a dead oocyte. It has some electrical charge in it. So yes, this can endoduplicate. This can endoduplicate and form a 46XX embryo. Now this would remind you of an embryo of a normal woman, a normal girl, isn't it? But yes, this is not how girls are made. Girls are made by a chromosome from the father and one chromosome from the mother. This one has both paternal chromosomes. Both the X chromosomes are of paternal origin. MCQ again. Paternal origin X chromosomes.
In the next one, we'll be discussing 25 PYQs from physiology. Don't break the streak and join us tomorrow. Do like the video and subscribe to the channel if you learned something new today. Till then, bye.